friends, greetings from the Global Academy of Medical Education. I'm Dr. Vaibhav Seth. So yesterday we had a discussion on the recall based questions that were asked in your FMGE January 2023 exam, medicine. And I'm thankful to my students who are scratching their head and exercising their temporal cortex and prefrontal cortex to retrieve some of the more questions that were asked in the exam. So I'm back here again and I shall be discussing some other questions that I could gather from my student. And since it's a recall based session, so there might be some discrepancy in the language of the question or in the options. If you feel that there is a discrepancy, that the certain option was not there, the language of the question is different, so you can comment in the comment box. And most importantly, at the end of the session, I shall be analyzing the paper that had come with an important message to all the participants who will be giving the exam next time, or those who will be appearing for the exam next time, and as an also important message to the candidates who shall be appearing for the NEET examination, NEET PG, right? Because the examination board is the same, NBE. And so I had initial plan of discussing somewhere close to 20-25 questions, but since there are certain questions that are common to other subjects also, so I have filtered out 10 to 15 questions that I will discuss in this lecture. And if you want to see the previous lecture that had covered somewhere 25 to 26 questions, you can go to the YouTube and log into the Global Academy of Medical Education channel. There you can see the video, right? So without wasting further time, let's start with the question. So you had a clinical case scenario where they are describing that the patient is having meningitis and a CSF has been done, which is showing low sugar with increased protein. So a CSF showing low sugar with increased protein levels. So this can be seen in two conditions, bacterial and tubercular. But the other option that you are having, chest x-ray showing upper lobe fibrosis with hilar lymphadenopathy, it cancels this option. So you are left with only one option, and that is tubercular. So your answer to this question would be, it is a case of tubercular meningitis. Okay, it is a case of tubercular meningitis. Next, another question from neurology. A 50-year-old patient presenting with headache and neck stiffness is being asked, right? Now, headache, neck stiffness and altered sensorium you can get in subarachnoid hemorrhage, you can get in meningitis. Encephalitis will not have neck stiffness, right? CVA also will not have neck stiffness. So whenever you are getting this triad of headache, altered sensorium plus neck stiffness, you should always think of subarachnoid hemorrhage. You should always think of subarachnoid hemorrhage. In subarachnoid hemorrhage, headache is being classically described as worst headache of life. It is classically described as worst headache of life. Now in the same question, if the patient had headache, patient had altered sensorium plus neck stiffness. Now if I add fever to it, the answer would turn into meningitis. So subarachnoid hemorrhage is basically meningitis minus fever. That's what you can say. Meningitis ka features minus fever. They do not have fever. So your answer would be subarachnoid hemorrhage. Answer to this question would be subarachnoid hemorrhage. Moving to the next question. The question was on Mucer mycosis and it was kind of expected. With so much of Mucer mycosis that we have seen in the Delta wave of the COVID, this question was really expected. So, Mucer mycosis, the question asked is which of the following is least contributive towards the development of Mucer mycosis? We know, yes, uncontrolled diabetes can develop Mucer mycosis. We know that immunosuppression due to steroid therapy is a risk factor for Mucer mycosis. So we are left with two options, either chronic use of antibiotics or neutropenia. So what you need to realize is neutropenia. If there is a neutropenia, that means the patient is immunosuppressed. So they are at the risk of developing mucormycosis. So automatically by exclusion, you can rule out these three options and you are left with option number D. So your answer to this question would be chronic use of antibiotics is not a risk factor for development of mucormycosis. Okay. Next question. This was an integrated neuro-opthal question. You can also integrate anatomy here. So they are asking you if you are getting a case of bitemporal hemianopia. Lesion कहाँ पे है? The question is if you are getting a case of bitemporal hemianopia, where is the lesion? So you know this pathway, optic pathway, right? You have the nasal fibers, and you have the temporal fibers, right? So the lesion is here. This will give rise to such a feature. If the lesion is here, this will be such a feature that you will get. So this particular area is basically called as optic chiasma. So lesions of optic chiasma. Will cause bitemporal hemianopia. Next question. This was asked, most common cause of death in diabetic ketoacidosis is. So what actually is diabetic ketoacidosis? It is very common in type 1 diabetics, right? Any sort of infection, stress, if you forget the dose of insulin, can precipitate diabetic ketoacidosis. For diabetic ketoacidosis, you need pH to be less than 7.2. You need urine ketone to be positive. And you need bicarbonate to be reduced. All these three criteria should be there. It should be fulfilled for the diagnosis of diabetic ketoacidosis. If it is fulfilled, then only you can say that the patient is having diabetic ketoacidosis. Prompt recognition of diabetic ketoacidosis is very important because it's a treatable condition, it's a treatable emergency. The mortality rate is very less than 5% in good setup. But the cause of death in diabetic ketoacidosis is usually due to cerebral edema. It is due to the cerebral edema, there is no other cause. The most common cause of death is mostly cerebral edema. Okay. Now, another question from neurology. A patient with tingling and numbness in the extremities, that means patient is having peripheral neuropathy. And in the imaging, you are showing that there is a subacute combined degeneration of the cord. Right? So what do I mean by the subacute combined degeneration of the cord? This means that the posterior column are affected. So if your posterior column are affected, your joint position sense and vibration will be affected. Right? So this is seen with vitamin B12 deficiency. This is seen with vitamin B12 deficiency, right? There are some other causes also. You can also see in cases of nitric oxide inhalation. Nitric oxide inhalation following dental procedures. Following dental procedures can cause subacute combined degeneration of the cord. Hypocupric myelopathy can also give rise to subacute combined degeneration of the cord. So here the answer is vitamin B12, but you should also remember the other causes, as the question can be twisted. They can give you a clinical scenario that after a dental extraction patient develop following symptoms, right? So what is the cause, right? Too much of zinc in your diet, too much of multivitamins containing zinc, and patient develops such symptoms, and imaging in the cord is showing that there is a subacute combined degeneration of the cord. So what will you suspect? So in that case, answer would be hypocupric. But in this case, the answer is vitamin B12. What you should know about vitamin B12 is that it causes peripheral neuropathy. And it's a very important cause of absent ankle reflex with extensor plantar. Right? There is absent ankle reflex with extensor plantar. Okay? Coming to the next question, if it was asked, where do you see facial deviation in Bell's palsy? So, what you should remember is, if this part of the face is paralyzed, then only this part of the face is having normal innervation. So this angle of the mouth is basically working. So you will have deviation of angle of mouth to normal side. You will have deviation of angle of mouth to normal side. Okay. Now what you need to remember here is a difference between LMN facial palsy and UMN facial palsy. In UMN facial palsy, the affected part of the face is usually contralateral. In LMN, the affected facial is mostly ipsilateral. In UMN, upper face is spared. Right? In LMN, the upper face is not spared. That's why you get something known as Bell's phenomenon. Okay. So this is an important piece of information that you need to keep about Bell's palsy. And what you need to also remember is the definition of Bell's palsy is idiopathic lower motor neuron 7th nerve palsy. Idiopathic lower motor neuron 7th nerve palsy. So if you have any cause, if you can find any cause of the 7th nerve palsy, then it will not be a case of Bell's palsy. Then there was a question on Guysbox syndrome. Guysbox syndrome is nothing but a case of spurious erythrocytosis. It's a case of spurious erythrocytosis or stress-induced erythrocytosis, right? So when you encounter a case of erythrocytosis, you have to differentiate whether actually you are having it absolute or relative, right? In relative erythrocytosis, what has happened, that there is a contraction of plasma volume. There is contraction of plasma volume, so that's why you get increase in hemoconcentration, and that is there is an increase in here. There is an increase in basically hemoconcentration. This is not a true thing. This is relative. This is spurious or stress related erythrocytosis. As you can see, among the causes of erythrocytosis, this is the table that I have taken from Harrison. So relative erythrocytosis is basically seen in those conditions which are secondary to dehydration, use of diuretics, ethanol abuse, androgens or tobacco abuse. So smokers, those who are heavy smokers and those who have COPD, those who are smokers and those who have COPD, they can have spuriously elevated hemoglobin. Right? But they do not have absolute erythrocytosis. So this is basically a one-line fancy word that is very common to be asked in NB based exam. They love such kind of fancy words. Okay. Then you have another question, a 60-year-old male who developed chest pain and shortness of breath after 10 to 15 days of bed rest, right? After 10 to 15 days of bed rest, what is the investigation of choice? So what you can make out from this clinical problem is the patient is having pulmonary embolism. And they are asking you the investigation of choice. Now, of all the investigations that they have mentioned here, all the investigations are somehow related to pulmonary embolism. They give you some information or the other about the pulmonary embolism, be it ECG, chest X-ray, D-dimer, pulmonary angio. But you are being asked here the investigation of choice. ECG will give you S1Q3 T3 pattern. It will give you S1Q3 T3 pattern, right? But this is not specific. Chest X-ray may be normal. D-dimer has got a negative predictive value. This has got a negative predictive value, right? That means if it is elevated, does not mean that you are having pulmonary embolism. But if it is negative, then it means you do not have pulmonary embolism. So that's the meaning of the word negative predictive value. Right? So you are left with only one answer, and that is the investigation of choice, and that is pulmonary angio. So pulmonary angio is basically the investigation of choice. So moving to the next question. Now you are asked, a 60-year-old male is having Cushing syndrome. So what is the most common cause? First, you need to differentiate what is a Cushing disease and what is a syndrome. So Cushing disease is basically part of the Cushing syndrome. Cushing disease specifically means there is increased cortisol due to pituitary adenoma. Right? So pituitary adenoma is the most common cause of Cushing disease. Now you are asked, a 60-year-old male with Cushing syndrome. The most common cause of Cushing syndrome is iatrogenic Cushing's, right? So in COVID-19, everybody was given glucocorticoids. Glucocorticoids भगवान है patient को बचाने के लिए. So all these patients will land up into iatrogenic Cushing's. So Cushing syndrome ka most common cause is iatrogenic. Now in your options, they have not given iatrogenic. They have not given use of exogenous corticosteroid. Right? So that means they are now asking you, they have given basically options about non-iatrogenic Cushing's. And non-iatrogenic Cushing ka most common cause is Cushing disease. Non-iatrogenic Cushing ka the most common cause is Cushing disease, right? और कुशिंग डिजीज का मोस्ट कॉमन कॉज होता है पिट्यूटरी एडिनोमा. द मोस्ट कॉमन कॉज इज पिट्यूटरी एडिनोमा. So the answer here would be pituitary adenoma. Okay. Next question, a bit controversial question. I'll tell you why. They are saying that 50-year-old lady is having hypercalcemia and elevated creatinine and bone marrow is showing plasma cells more than 40%. I just hope the number that I have got from the recall is 40%. Okay. So you are having features of hypercalcemia. So you know that in multiple myeloma you get organ damage in the, and that is a mnemonic that we commonly refer to known as the CRAB, where you have hypercalcemia, you have renal failure, you have anemia, and you have lytic lesion. So any one of them could be present. Along with that, you need to have a clonal plasma cell population more than 60% to diagnose multiple myeloma, right? To diagnose multiple myeloma. But here you have been given a percentage of 40. So students who are listening to this, please comment in the comment box whether you were given option of 40 or not. Because this patient is definitely symptomatic. Is definitely having symptom. Having said that, patient is having hypercalcemia with elevated creatinine. Now, I'll show you a table from Harrison where they have the diagnostic criteria of different plasma cell disorder. The number 10 to 60%. The number 10 to 60% is basically reserved for asymptomatic multiple myeloma. Asymptomatic myeloma, also known as the smoldering myeloma, right? Also known as the smoldering myeloma. And to call it a multiple myeloma, you need to have a clonal proliferation of more than 60%. The population of plasma cells should be more than 60%. But here it is 40%. But I guess you cannot call it a asymptomatic multiple myeloma here, considering the symptoms they have. So either this could be a sampling error or this could be a recall error. But given the options and given the scenario, our answer would be multiple myeloma, right? So let's go through this table that you have in Harrison. So plasma cell disorder, basically plasma cell disorder, the plasma cell disorder plasma cell disorder, it can be MGUS, which is monoclonal gammopathy of undetermined significance. It could be a asymptomatic myeloma, or it could be a symptomatic multiple myeloma, right? Now, each of these have got its own criteria. So what you need to remember is these patients have got percentage less than 10%. The myeloma cells in the bone marrow is less than 10%. And they definitely do not have any CRAB features. They do not have any CRAB features, right? And the serum monoclonal myeloprotein is also less than 3 gram per dl. The M band that you get is less than 3 gram per dl. In asymptomatic multiple myeloma, you do not have any CRAB. But the population of the cell is between 10 to 60%. The population of the cell is between 10 to 60%, right? Is between 10 to 60%. Is between 10 to 60%. Okay. Coming to the symptomatic myeloma, they have one feature of CRAB and one feature of clonal cell proliferation more than 60%. So they have this CRAB. Along with that, you have clonal plasma cell more than 60%, and you have clonal plasma cell that is more than 60%. So this is basically a short synopsis on plasma cell disorder, how you characterize each of this disorder. This year you have got question on multiple myeloma. Next year probably you can get a question on MGUS or smoldering multiple myeloma. Okay. Yeah. So next question from Gastro. Alcoholic patient with pain in the epigastrium. An alcoholic patient who has got pain in the epigastrium and it's a radiation to back. This is an important line. Just mere pain in the epigastrium can have lot of other causes also. It can be a peptic ulcer disease. It can be Bourhaave syndrome, which alcoholics are very common to have. Mallory Weiss tear. All these can present with pain in the epigastrium. The most important clinical thing that they have given here is radiation to back. So they are giving you radiation to back. So this is a case of acute pancreatitis. This is a case of acute pancreatitis. But friends, remember that the most common cause of acute pancreatitis is gallstones. And second most common is alcoholic. But given the clinical scenario that you have been asked here, the answer would be acute pancreatitis. These patients usually have got elevation of amylase and lipase level. They have got elevation of amylase and lipase level. The lipase level is more specific. The lipase level is more specific. And not to forget, you get certain clinical sign, which is Cullen sign and the Turner sign, right? Cullen sign and the Turner sign. This you get in the umbilicus, where there is bruise and discoloration, and Turner sign you get in flanks. Right? So next question. A female with heliotrope rash and unable to comb her weakness. That means there is a skin rash. Along with that, there is a evidence of proximal muscle weakness. So there is only one DD with skin rash and proximal muscle weakness is dermatomyositis. Right? In SLE also you can have presence of rash with proximal muscle weakness. But remember, in SLE what you have is a malar rash. In dermatomyositis you have got the heliotrope rash. But this is not the only rash that you get in dermatomyositis. Along with that rash, you can also get skin manifestations in dermatomyositis. So there is heliotrope rash. You can have Gottron papule. You can have Gottron rash. You can have this thing, nail bed telangiectasia. So all these features you can see in dermatomyositis, which is nothing but a case of inflammatory myopathy. These are all inflammatory myopathy. So from the clinical statement, you are very much clear that unable to comb her hair. Means you are this is involving the use of your proximal muscle. Had it been unable to grip, that means the distal muscle is being involved. But unable to comb her hair, unable to lift her hand above her shoulder level. These are all different actions which requires the use of proximal muscle. So you have a rash and you are unable to comb the hair. So proximal facial meshes with skin rash. So you have to think of dermatomyositis. So the answer here would be dermatomyositis. Okay. Yeah. Next question. Which ganglion is involved in Ramsay-Hunt syndrome? So it is basically the integration of anatomy and neurology. Ramsay-Hunt syndrome basically involves the facial nerve. So if there is an involvement of facial nerve, which ganglion will be involved? The answer is geniculate. Ganglion. So no other answer to that. Your answer would be geniculate ganglion. Okay. Yeah. Next question from hematology. Features of hemolysis. So what are the basically features of hemolysis? You can get normal to reduced hemoglobin. You will get elevation of bilirubin. Which bilirubin will be elevated? mostly unconjugated, right? You can get splenomegaly. You can get reticulocytosis. Because of reticulocytosis, you will get increase in MCV. You will get decreased haptoglobin. You will get decreased haptoglobin and you will get increased LDH. So going through the options, normal hemoglobin. Yes, you can get normal hemoglobin. Normal to reduced hemoglobin can be seen in hemolysis. Decreased LDH, no, you do not get decreased LDH, you get increased LDH, right? So decreased haptoglobin is the best answer here. Decreased haptoglobin is the best answer here, okay? Yeah, so now coming to the final analysis of the paper, I have discussed somewhere close to 41 questions in medicine that have been asked. So अब analysis of paper अगर करें तो NBE always has got affiliation to, I mean they always have got affection towards the fancy one-liners. Fancy one-liners की तरफ उनका प्यार हमेशा से रहा है. Like Guysbox syndrome, ये सारे questions वो पूछते रहते हैं. तो whenever you start reading, so give emphasis on some fancy one-liners, some fancy one-liner words which can be asked, some syndrome they can ask you. Samter's triad पे question पूछ लिया, Guysbox syndrome पे question पूछ लिया. तो आगे के लिए भी आपको इस चीज़ के लिए जान के रखना है कि ऐसे questions आपके लिए आ सकते हैं. दूसरा, there has been emphasis on the integrated questions. There has been emphasis on integrated questions. So you guys have been seeing videos of so many recalls that is there in the YouTube. So many faculties are teaching. So you will see some questions are common to all the faculties. Physiology का भी faculty पढ़ा रहे हैं, medicine के भी faculty वही question पढ़ा रहे हैं, opthal के faculty भी वही question पढ़ा रहे हैं, pharma के भी faculty वही question पढ़ा रहे हैं. So basically integrated clinics. They are connecting the questions of physiology with medicine. Pharma का question is being connected to medicine. Neuro का question is being connected to opthal. All these things are there. Opthal ka question is being connected to anatomy. So every question that is being framed in such a way that they have an integration, they have its use in clinics. Dusra, coming to the medicine point of view, I always tell my students that you cannot neglect neurology for your exam. You cannot neglect neurology for your exam. There will be good 7 to 8 questions, whatever exam you give. There will be good 7 to 8 questions from neurology. And this time there were 7 to 8 questions. Myasthenia gravis में 2 क्वेश्चन, dermatomyositis पे क्वेश्चन आया. उसके बाद they are asking you on Bell's palsy, 3 questions on Bell's palsy. They are asking you questions on neuropathy, 2 to 3 questions on neuropathy. So यार 10 questions तो ऐसे ही हो गए neurology से. So you cannot neglect neurology because the questions from neurology that they ask is mostly very basics and people are afraid of neurology. So that will not work for your exam. So if you have not read neurology and you are thinking that you will go to the exam without studying neurology, that is not there. That वो नहीं चलेगा, ये ट्रिक नहीं चलेगी. आपको न्यूरोलॉजी पढ़ना पड़ेगा, न्यूरोलॉजी की बेसिक्स आपको आनी चाहिए. So if this is a message for those who are planning to give the exam in the June or those who are preparing for the NEET PG examination that will come in this is there in the March. So you've got less time, but brush up your basics in neurology. Brush up your basics. यहाँ पे भी अगर सवाल आए हैं तो वहाँ पे भी आएंगे. So neurology would be a game changer. Neurology will be a game changer. अगर आपने 10 क्वेश्चन यहाँ पे आंसर कर दिए तो आपकी गेम ही अलग हो जाएगी. ठीक है. Second is PYQs. You cannot miss the PYQs. Do not miss the PYQs. गाउट पे 3 क्वेश्चन आया. गाउट पे रेगुलरली क्वेश्चन आता है. गाउट जैसा टॉपिक आप छोड़ नहीं सकते. JVP जैसा टॉपिक आप छोड़ नहीं सकते. मायस्थीनिया ग्रेविस जैसा टॉपिक आप छोड़ नहीं सकते. बेल्स पैल्सी जैसा टॉपिक आप छोड़ नहीं सकते. तो टॉपिक उठाओ, रेट्रोगेट मेथड में पढ़ो, टॉपिक उठाओ, उसके क्या क्या क्वेश्चंस आए हैं देखो, उसका ऊपर नीचे चीज़ देखो, उस हिसाब से पढ़ो. तो आई थिंक दिस इज व्हाट आई वुड लाइक टू से एंड ऑल द बेस्ट टू दोज हु हैव गिवन द एग्जाम. आई एम श्योर दैट आपका रिजल्ट अच्छा रहेगा. एंड इफ यू हैव एनी डिस्क्रिपेंसी विद regards to the question that I have taught here, and if you have any question, and many students have also told me that they want the PDF of the recall session that I have done. Okay, PDF आपको मिल जाएगा. You can DM me on Instagram for the PDF. And if you have any queries, you can contact me, you can DM me on Instagram. और अगर आपको PDF चाहिए, PDF आपको मिल जाएगा. And I hope you all the best.